Alright, so I'm going to do my presentation on sleep apneas and disturbances. So, central sleep apnea is pretty much a cessation in airflow of 10 or more seconds without any inspiratory effort. And it's been diagnosed when 50% or more of those events are central. Typically, apneas are found by using oral nasal thermal sensor signals. What's even better is using an esophageal balloon catheter, but that's not as common, obviously. And we can also do respiratory inductance, plethysmography, and strain gauges. And a frequency of 5 or more apneas per hour is considered abnormal. It is useful to divide the syndromes into two groups, the hypocapnic and hypercapnic groups. The hypocapnic groups have a normal or low wake PaCO2 and do not develop sleep hypercapnia. So this will have patients with ICSA, which is pretty much idiopathic central sleep apnea, Cheyne-Stokes breathing, and complex CSA, central sleep apnea. The hypercapnic group has wake high normal or elevated wake PaCO2, and this has patients with CSA due to drug or substance and primary CSA of infancy. Patients with obesity, hypoventilation syndrome, thoracic cage disorders, neuromuscular disorders, complex sleep apnea are patients who have primarily OSA or mixed apneas who develop central apneas on positive airway pressure. As far as pathophysiology goes of central sleep apnea, you have breathing and non-rapid eye movement, or we call that non-REM or NREM. Sleep respiratory control is unstable during transition from wake to sleep and with further sleep stage transitions. There's usually about a 2 to 8 millimeter mercury rise in PaCO2 during non-REM sleep. During non-REM sleep, ventilation is totally under metabolic control. The wakefulness drive is no longer optional, and the hypercapnic and hypoxic drives are lower, and there's more upper airway resistance. Breathing in REM sleep. REM sleep is really characterized by generalized skeletal muscle atonia, leaving the diaphragm as the main active respiratory muscle. There's further reduction of the hypercapnic and hypoxic drives. There's also more inhibition of upper airway muscles and diaphragmatic activity in phasic REM, which may lead to episodes of CSA and reduced tidal volumes. As far as the AT or the apneic thresholds, the PaCO2 falls below a patient's set value as CSA will follow, and then ventilation will only resume after the PaCO2 has risen above that threshold. The sleeping PaCO2, like I said earlier, was 2 to 8 millimeters mercury above the wake level. The apnea threshold, or the AT, is usually 1 to 2 millimeters of mercury lower than the waking PaCO2. And the important thing that determines a tendency to develop an apnea is the difference between the patient's CO2 and the AT. The smaller the CO2 AT difference, the more likely it is that a central sleep apnea will occur. As far as ICSA or idiopathic CSA, as far as pathogenesis or etiology, it's still pretty unclear. It's really a diagnosis of exclusion after excluding the known cause of CSA. Patients are usually not obese. Symptoms are obviously disturbed sleep, insomnia, witnessed apneas, and some daytime sleepiness. Snoring isn't as intrusive as an OSA or obstructive sleep apnea. These patients tend to have a high hypercapnic response and sleep state instability. Wake CO2 levels tend to be low. Arousal is usually non-respiratory related, cause a transient increase in ventilation and consequent fall in PaCO2. Polysomnographic studies show frequent central apneas or runs in central apneas, and they occur in non-REM sleep and mostly arise from stages 1 and 2. Treatments consist of respiratory stimulants, hypnotics, CPAP, and oxygen. The carbonic anhydrase inhibitor acetylzolamide, which induces a metabolic acidosis, has been shown to reduce AHI by as much as 50%, but has a doubtful impact on sleep efficiency. Hypnotics work by suppressing the arousal response and consolidating sleep. Stage 3 non-REM sleep is increased and CO2 levels are higher and respiratory is more stable. And usually we use CPAP. to treat the ICSA, and it probably works by stabilizing the upper airways and abolishing the upper airway resistance related arousals, and it might also minimize the CO2 overshoots after an arousal. It's also been suggested that it might slightly increase the sleeping CO2 in patients who are hypocapnic at baseline. Now to kind of go over complex sleep apnea syndromes, and most patients are typically diagnosed with OSA, or obstructive sleep apnea. And as most people know, CPAP is usually the first line of non-invasive treatment, and it can suppress obstructive respiratory events. But it's been noted that in some of the clinics that some patients presenting predominantly with OSA baseline experience accompanying central sleep apnea events after tracheostomy or CPAP. So complex sleep disordered breathing is a new name for this, and it's actually termed complex sleep apnea syndrome. There's a lot of controversy. Some researchers think that the disease is pretty much a unique entity, and others think that it's not a disease, but it's pretty much just a defined group of entities with varying etiologies. I personally just call it complex apnea. Inadequate or excessive titration, substantial mass leak leaving residual evidence, residual sleepiness or CPAP, and sleep transient apneas upon CPAP initiation. Now to kind of go like a little bit on a more of a molecular level, the chemoreceptor inputs are pretty much the medullary neurons responding to CO2 by the shifts in hydrogen concentration peripherally at the carotid body via the PaO2 and PaCO2. Those all play a key role in modulating ventilation. So in most cases, the major determinant of minute ventilation is PaCO2. The CO2 is tightly maintained near 40 millimeters of mercury during wakefulness. During sleep, the chemosensitivity to both CO2 and O2 falls and varies with sleep stage. A mean PaCO2 of 45 millimeters of mercury happens during stable sleep. Behavioral influences and neurocompensatory responses strongly inhibit apnea, even in drops of PaCO2 during wakefulness. This is not the case during sleep. During sleep, all patients are susceptible to breathing cessation when PaCO2 falls below a critical threshold known as apnea threshold. The vent output to a given change of PaO2 or PaCO2 can really vary a lot with the disease status. So highly sensitive chemoresponses can actually place a patient at risk for unstable breathing patterns because they over-respond to small changes in the chemical stimuli. So as an example, to a given increase in the CO2, a person with high chemosensitivity will respond by increasing ventilation to a greater extent than someone with a lower chemosensitivity. The more ventilation will continue until the resultant drop in PaCO2 is detected by the chemoreceptors. So people with high chemoresponsiveness will hyperventilate, markedly lowering the CO2 below the eupneic level and leading to a hypopnea and potential apnea. This could be explained by loop gains, and high loop gain may be the mechanism for all central disordered breathing patterns. So loop gain is a measure of the stability or instability in the vent control system. It's the ratio of a corrective response to disturbance. So if corrective responses are greater than disturbance, then small disturbances can lead to self-sustaining oscillations. Those with high loop gain are prone to instability, whereas those with low loop gain are resistant to periodic breathing. Assessed vent loop gain with a proportional assist ventilation technique. And in one of the studies I read, it showed that people with a higher loop gain developed a periodic breathing with minimal proportional assist ventilation support, when those with low loop gain do not develop periodic breathing, even with a lot of proportional assist ventilation. So there must be anatomic or physiologic vulnerability to OSA plus essential breathing control instability leading to the chemoreflex dysfunction. And in the study that I was reading, their loop gain theory was approximate proximity of sleep apneic threshold to awake the PaCO2, low arousal thresholds, and incomplete control of obstruction have all been made to contribute to the development of complex sleep apnea. And changes in CO2 excretion occur with the relief of upper airway obstruction. A high upper airway resistance can dampen the vent control system, reducing the efficiency of CO2 excretion. And with CPAP, the upper airway is opened by effectively removing the large resistance from the respiratory system, and the efficiency of CO2 excretion is improved, which pretty much equals hypocapnia. And if the CO2 falls below the CO2 apnea threshold, the cessation in respiratory effort may be expected over the course of several days to weeks. The CO2 apnea threshold may or may not improve, which means that the resolution of central apnea, or maybe not. Other factors are like over titration of CPAP is thought to lead to central apnea, but we don't really know why. One reason may be that the activation of lung stretch receptors may inhibit the central respiratory motor output. Another one is washing out of the CO2 from the anatomical dead space may occur if the mask leak or mouth breathing develop at high CPAP levels. CPAP could worsen sleep quality. The transitions from sleep to wake can contribute to sleep central apneas with instability. If that happens, then the vent response to arousal can drive the CO2 below the CO2 apnea threshold, yielding central apnea during the subsequent sleep. And CPAP intolerance secondary to an elevated nasal resistance may relate to frequent arousals, which could presumably contribute to the increase of CSA. Common risk factors would be like systolic heart failure, AFib, cerebrovascular diseases, and opioid drug use. And actually, in the study that I found, that complex sleep apnea is more common in patients with CHF, and with more numbers of patients with CSF being screened to treat OSA, it could be an increasing clinical problem associated with complex sleep apnea. And patients with complex sleep apnea had lower diastolic blood pressure and a lower rate of diuretic use. As far as treatment goes, the goal really is to normalize the apnea-hypopnea index, or AHI, and sleep architecture in order to lower the complications and improve quality of life. And patients with complex sleep apnea may have a poor initial experience with CPAP, but some central sleep apnea events during initial CPAP titration are transient. They could disappear after continued CPAP use. So CPAP is still the first-line treatment of complex sleep apnea. There's also, ASV, bilevel oxygen, CO2 medication. Now to kind of go over central hypoventilation syndromes, which is actually something that I see every now and then at my hospital, which is it's actually pretty sad to see. But so pretty much hypoventilation is where as an increased arterial concentration of serum carbon dioxide due to inadequate gas exchange. Central hypoventilation tells us that there's a deficiency in the central nervous system rather than the respiratory system is the root of the problem. Central hypoventilation is uncommon and may be due to a variety of conditions, which can be either congenital or acquired. There's a lot of genetics that play into this. So I'm going to refer to congenital central hypoventilation syndrome as CCHS. It's pretty rare. It's lifelong. That causes primary alveolar hypoventilation. The paired like homeobox 2b gene on chromosome 4p12 is a disease-defining gene for CCHS. Transmission is through an autosomal dominant pattern, but most cases CCHS are de novo or inherited by from a mosaic, typically unaffected parent. PHOX2B encodes a transcription factor that is instrumental in the regulation of neural crest migration, development of the autonomic nervous system. Most patients with CCHS are heterozygous for an inframe polyalanine repeat of the 20 residue polyalanine region, but the normal genotype is referred to as 2020. These mutated proteins produce genotypes of 2024 to 2033. And then the remaining 10% of PHOX2B mutations are non-polylalanine alanine, my apologies, repeat mutations causing the missense, nonsense, or frame shifts. So as far as how these kids look like, It usually happens during infancy, where they have cyanosis, apnea, cardiorespiratory arrests. They've been described as having a square face with a tall, flat forehead and deep philtrum with downturned lips. The phenotype is more prevalent with increased polyalanine repeats. There may be ophthalmic clues to a diagnosis of CCHS as well. These kids may have sluggish or absent papillary light reflex, strabismus, or convergence insufficiency in patients presenting late in the course may have evidence of right heart failure or developmentally delayed. Kids diagnosed over 1 month of age is usually termed late onset, and these kids have the 2024-2025 genotypes and rarely have NPARMs. As far as the degree of hypoventilation in patients with CCHS, it's variable, but most kids ventilate adequately during wakefulness. Approximately 15% require vent support, even when awake, and typically a greater number of polyalanine repeats correlate with more severe hypoventilation, with those having 2027 and 2033 genotypes, often needing vent support during sleep and wakefulness because they lack a response to hypercapnia and hypoxemia, and they do not adequately augment respiratory effort required during vent challenges such as illness or exercise. And what's interesting in the study I found, it showed a positive correlation between treadmill pace and respiratory rate. Oxygen sats decrease and CO2 tension increase during exercise in patients with CCHS, but not controls in this study. As far as the pathophysiology, it's still not well understood. Multiple studies have been done, central and peripheral chemoreceptor function in these kids, and these patients have been shown to have peripheral chemoreceptor response similar to controls when given rapid challenges of hyperoxic and hypercarbonic gas, which means that the peripheral chemoreceptors are present and functioning in patients with CCHS who can ventilate adequately when awake. But classic rebreathing response to longer hypoxic or hypercapnic challenges are abnormal. One study did focus on the respiratory-related evoked potentials, found disrupted central integration of the afferent signal during wakefulness and reduced responses during non-REM sleep in patients with central hypoventilation syndrome. Another one that I found compared with controls, patients with CCHS had no difference in cough threshold when evoked by fog inhalation, but those with CCHS lacked respiratory sensations or increased in ventilation before coughing. MRIs have been used to evaluate the central nervous system signal responses in the brains of people. Delayed responses have been demonstrated in the medullary sensory regions, limbic areas, and cerebellar and pontine sensory-motor coordination areas in patients with CCHS during Valsalva. MRI studies evaluating response to hyperoxia have been shown altered responses to the amygdala, which normally regulates respiratory timing, as well as blunted heart rate responses in patients with CCHS. Combination of findings underlies the autonomic dysfunction central to these kids and supports the hypothesis to deficiencies in central integration of chemoreceptor inputs rather than the receptors themselves are likely responsible for the autonomic dysfunction and loss of respiratory drive. And yeah, as far as diagnostic evaluations, there's a two-stage blood test available for the diagnosis, and this should be sent in any case where diagnosis is considered. The PHO-X2B screening test is a gel electrophoresis that evaluates for the polyalanine repeat mutations in the most common NPARMs. It's capable of identifying 95% of these cases, and if the test is negative and the phenotype supports the diagnosis, the PHO-X2B sequencing test can be performed. Hemoglobin and hematocrit or polycythemia and blood gas with bicarb levels should be considered to evaluate for respiratory acidosis, metabolic acidosis. You can do echoes, EKGs, brain type natriuretic peptide levels should be considered. Um, Polysomnography can be helpful in these, and they should include, wakefulness, REM, and non-REM to determine how bad the hypoventilation is. Vent response testing has been also used. Yeah, and I mean, as far as management goes, they usually require mechanical ventilation, some oxygen, respiratory stimulants, and infants may require continuous ventilation because of a immature respiratory system. Um, some infants will actually, well, for the kid that I had with Rohad syndrome, who came in, it took a while to convince his family to, because we had to. He constantly came in and he'd be on BiPAP for it first started out with BiPAP at night, then it got escalated to continuous BiPAP. Then it just kept getting worse and worse. He was intubated for over a month, and then after having many meetings with the family, we finally agreed to trach him. And now his quality of life has improved dramatically. I barely see him in the hospital anymore. He's pretty much just on the trach. He has a trach, and he has a vent, like a little vent with him everywhere he goes, because he doesn't have that central nervous system stimulation to help, like, to kind of tell him to breathe. So that's So either way, I still keep in contact with him, and he's very happy with the trach actually. And he was only, I think he was 11 years old when we trached him. So it was like a long ongoing thing that we had going on with this patient. But yeah, I mean, vent support, positive pressure ventilation, negative pressure ventilation, diaphragmatic pacing, respiratory stimulants. These are all just general things that they might need, or options for as far as management treatment goes. Now, last but not least, something that many people are probably they probably know, obstructive sleep apnea. Um, you know, it's pretty much all that snoring that's going on, um, and pretty much some of the symptoms are daytime sleepiness, loud snoring, restless sleep, and the gold standard to diagnose it is polysomnography. A detailed um, history and focused physical exam can actually help diagnose it. If it's undetected, it can lead to hypertension, heart disease, depression, and even death. Um, like I said, we can use CPAP, oral appliances. There's also surgical procedures that can help with this, but the best thing to do is kind of educate these patients and their families to try to reduce alcohol or intake or tobacco, and try to lose weight. A lot of it has to do with obesity, all that fat tissue in the upper airway. As far as pathophysiology goes, it's caused by repetitive bouts of upper airway obstruction during sleep as a result of the narrowing of respiratory passages. The most common site of obstruction is the nasopharynx. It's important to differentiate OSA from the less common central sleep apnea, which is caused by an imbalance of the brain's respiratory control centers during sleep. While the pathogenesis of OSA is thought to be multifactorial, anatomic defects are thought to play a major role. Characteristics can, like I said, just be obesity, thickened lateral pharyngeal walls, nasal congestion, a large uvula, facial malformations, micronathia, microglossia, tonsillar hypertrophy, and obesity, of course, contributes to airway narrowing through fatty infiltration of the tongue, soft palate, and other areas around the airway. When the patient falls asleep, muscles of the nasopharynx begin to relax, and the surrounding tissue collapses, causing compromise of the airway. As oxygen levels in the body start to drop, the CO2 levels rise, and the patient is aroused from sleep. This causes an increase in sympathetic tone and subsequent contraction of nasopharyngeal tissue, which allows alleviation of the obstruction. Upon the patient's falling back to sleep, the airway is again subjected to narrowing until the patient is aroused from sleep once again. The cycle continues throughout the night, causing decreased time spent in rapid eye movement sleep and an overall decrease in quality of sleep because the gravity-dependent factors that we talked about a little bit before most obstructive symptoms happen in the supine position. So, contributing to anatomic causes of this disorder is well defined as neural component. A lot of studies have been done that natural response to negative pharyngeal pressure are already diminished during sleep. Sleep disruption itself can lead to a further reduction in upper airway muscle activation, causing exacerbation of the aforementioned symptoms. Several studies have been explored. They kind of explore the repetitive short cycles of oxygen sats that are followed by rapid reoxygenation. Periods of hypoxemia inhibit the synthesis of nitrous oxide, a potent vasodilator, directly influencing the vascular beds. Episodes of hypoxia can cause activation of the various inflammatory cells that are potentially damaging to endothelial cells and predispose patients to the development of atherosclerotic lesions. As far as management, we already kind of talked about it. It really depends on the severity and duration, how bad the symptoms are. If the patient's overweight and we try to educate them to weight loss, studies actually show that about 10% of weight loss is associated with a 26% reduction in apnea-hypopnea index scores. For really obese patients, bariatric surgery may be considered, and it can actually relieve the OSA to up to 86%. And obviously, tell the patient to stop drinking alcohol or smoking. That can obviously help it too, and as well as try sleeping on their side rather than in a supine position. First line therapy, like I talked about earlier with CPAP, kind of maintains a pain airway. And let's see what else there could be. However, though, with CPAP, patient compliance is really only about 50-60% because, patients obviously get, upset with like the mask leaking or they just, they get claustrophobic or something like that. They get nasal congestion. There's also BiPAP. And then, we can do, for the patients who feel like they're getting like really little benefit from the CPAP or oral appliances, we could do surgery. The most common surgical procedure is the uvulopalatopharyngeoplasty, where the palatine tonsils and the uvula and the posterior palate are resected, and the tonsillar pillars are reoriented in hopes of establishing a larger airway. And the effectiveness of the procedure is only about 50%. Your last resort would be a trach, which is pretty much the definitive form of treatment for patients with severe life-threatening sleep apnea who are unresponsive to other treatment options. And overall, thanks for listening, and these are my references.